Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami for our Monday afternoon Instagram chat. Today's topic is what factors influence success rates with IVF? This is a great question. It's the most common one that are asked by patients in different ways. What are my odds of this process working? What things can I do to make it better or not better? And so it's really important to get an understanding of the different factors that can affect IVF success rate and why sometimes it's difficult to pin down a real precise number for an individual patient. In general, IVF is quite ubiquitous in that it's a procedure that can be used for multiple causes of infertility. It requires sperm from a sperm source, eggs from an egg source, with fertilization, embryo development, and then transfer of the embryo. And the single most important factor that affects IVF success rate is the quality of the embryo that's going to be transferred. It's just no different than cooking a really good cake, in that if it's good ingredients in, it's usually good ingredients out and a nice outcome at the end of the day. In this case, we're creating embryos in a laboratory, and the two biggest factors in how good a quality of an embryo we're going to get have to do with the quality of the egg and the quality of the sperm. The sperm, more often than not, is going to be adequate even if sperm counts are very low. On the male side, we just need sperm that are active and motile. It doesn't matter if they come from the ejaculate, if they've been stored in a freezer from donor sperm or cryopreserved sperm in your husband or patient. And it doesn't matter if it's come from an aspirate of the epididymis or an aspirate of the testicle. The key is that we have live sperm at the time that we're using the sperm. If you inject eggs with sperm that aren't motile, we don't know if the sperm is live or dead, and if the sperm is not moving, the only thing we can do to test it will kill it. So we don't want to do that, and so you want to have live sperm to work with. Most of our patients will have live sperm, so the male factor is that. On the female side, egg quality becomes very important, and egg quality is usually initially determined by looking at the eggs under the microscope. You need to have what are called mature eggs, which are capable of being fertilized. These are eggs that have completed the first meiotic division, they've extruded a polar body, and are ready to be fertilized basically by the sperm. Now, what factors, how do you tell if you have good quality eggs? You won't know with certainty until you get the eggs. The predictive factors are how well you're going to respond to fertility drugs, how old you are. The younger the patient, usually the better that you respond to fertility drugs. Biologic markers such as FSH, follicle stimulating hormone, AMH, anti-Müllerian hormone, antral follicle counts on ultrasound. All these things will give you some degree of predictive value on the quantity of the eggs that we're going to get, as well as some idea of the quality of them. If you have mature eggs and you fertilize them with mature sperm, you can usually expect a reasonable fertilization rate. And in general, about 75% of 75% of eggs of good quality are going to fertilize. The embryos will form, and usually 40 to 50% of those embryos will continue to develop to a blastocyst stage of development. So the more eggs that are good quality to start with, the more embryos that we have forming down the road 5 to 6 days later. This is important because if you go test those embryos to check if they're competent from a genetic standpoint, if you do pre-implantation genetic testing and you check for aneuploidy, meaning an abnormal number of chromosomes, what you find is that women that are older have much higher incidences of aneuploidy than women that are younger. And if you look at large groups of patients, in women that are 30 years old and younger, 70% of embryos that make it to the blastocyst stage are going to have normal euploid genetic complement when you test it. However, if you take women 42, it's going to be the opposite. 80% of the embryos that look great under the microscope, when you test them genetically, are not going to be normal. So the concern is always the older you are, the less reserve you have of the ovary, the less number of eggs you make, the higher the incidence of aneuploidy, and the lower likelihood that we're going to get a good quality normal embryo. So the first and the most important aspect of success with IVF is what are our expectations of getting good quality embryos. And that's going to determine if we have adequate sperm. It's going to be determined by the age of the woman that we got the eggs from and how many eggs we have, and then there'll be an expectation of how many would develop normally. The second issue that goes along with that is obviously the quality of the laboratory. We've been doing IVF now for 30 years. Our embryologist has, all three of our embryologists have extensive experience in embryology for many, many years, and are very well versed in handling eggs and embryos, and we have a good IVF lab. So we're not worried about the mechanics of what we're doing. We have special filters in the ceiling. We have these life air filters that filter out volatile compounds. We're constantly testing the environment to make sure that things are good and healthy for embryos to grow. And we have lots of safeguards in place to make sure that from a technical standpoint we're doing things right, and the lab is more than capable of producing good quality embryos. Once we have normal embryos, the next are going to be, what are we going to do with these embryos? We're going to transfer them back into the uterus. And embryo transfer becomes an important aspect of outcome as well. We perform almost all of our transfers now under abdominal pelvic ultrasound, so that we can actually see a catheter get into the uterus and make sure we put it in the right spot. We want to transfer the embryo a centimeter and a half from the top of the uterus and the upper, right about at the break between the lower 2/3 and the upper third of the endometrial cavity. It seems to be the sweet spot for transferring embryos. In our program, we usually have done a measurement at the time of hysteroscopy or immediately before doing the embryo transfer. We'll do a vaginal ultrasound and remeasure the length of the endometrial lining. So, technical aspect, we got to get the embryo in the right spot. It means using the best catheter for the procedure. The technical ability of the person doing it, again, the only people doing embryo transfers in the office are myself, Dr. Ackerman, and Dr. Chung. All three of us are very well versed and very capable of getting the embryos in the right spot, even with very, very difficult patients. So you're in good hands with us in the lab. You're in good hands with us medically with the things that have to get done from a technical side. And then the last aspect of things are, what about the uterus and the host? So we've got, so far, quality of eggs and sperm resulting in the quality of the embryo. The technical aspects in growing that embryo in the lab, the genetic aspects to make sure it's a normal embryo, and the technical aspect of getting this embryo back into the uterus. And the last factor is, what about the uterus itself? A normal uterus is going to have a lot better chance of having a successful implantation than a uterus that's not normal. And we've done things before we've gotten to this point to try and show that the uterus is normal. There should not be any fibroids in the cavity of the uterus, preferably no scar tissue in the uterus. The uterus should have a normal shape and size. the absence of adenomyosis, which is endometriosis in the muscle wall of the uterus, the absence of low-grade chronic inflammation in the uterus. Any of these factors that I just mentioned will make it harder for an embryo to stick when you put it into the uterus. So in general, when you go, what are my chances of getting pregnant? The single most determinant and the simplest way to answer the question is to ask someone how old they are. And they sort of fall into a different category of, if you're under 30, you're 30 to 35, 35 to 37 to 40, 40 to 42, or over 43. And then it's a matter of how do we want to express the pregnancy outcome? Is it babies born, which is what we ideally would like to see, their ongoing pregnancies or babies born, as a reflection of the embryo transfer procedure. The ASRM data is usually per egg retrieval process, and it's important to understand the differences there, in that if you express results, if you talk to people with results, and it's important for you to talk to your doctor so you understand you're talking the same language. If you're speaking about pregnancy results per egg retrieval, you're going to have much lower success rates than embryo pregnancy results per embryo transfer. And the reason is that some patients won't have any embryos to put back. If you're 45 years old and we're trying to stimulate you with your own eggs, in general, if you take 1,000 people age 45 and you did IVF on them knowing nothing else, your chances of success rate is going to be under 1% with their own eggs. But if they happen to produce a normal embryo from the 1 or 2 or 3 eggs that they make, then they've got a pretty good chance of that embryo working, as long as the uterus itself is okay. If you look at women age 30, most women age 30 have good ovaries, produce eggs. Most women age 30 have good uteruses. If you look at women when they get older, they have less eggs, less reserve, and they have other confounding variables. They can have fibroids, they can have adenomyosis, chronic inflammation, they could have past pelvic uterine surgery, endometrial curettages. And so the age is helpful to give a general ballpark of where you fall. And then we can fine tune that by looking at your ovarian reserve, your AMH, to see how you're going to respond to fertility drugs. We can modify that by the how you respond to fertility drugs and make a lot of eggs or few eggs. And then obviously the issue of the uterine environment. And besides the anatomic environment, which I've addressed a little bit with fibroids, adenomyosis, chronic inflammation, you also have things that we can't necessarily see, in that the uterus is normal, but you have some patients that they just have implantation failure. And is that due to the presence of natural killer cells, an overactive immune system? Is it related to antiphospholipid antibody syndrome, of your body producing antibodies that's recognizing the embryo as something foreign and trying to get rid of it, or excess clotting in the microcirculation? So all these other things can also play a role if we see that recurrent implantation doesn't succeed. So, the key things to understand is that in order to end up with a good chance of getting pregnant, we need a bunch of eggs to start with. And as one of you brought up, you can have 25 or 30 eggs, and at the end of the day may only have one embryo. But not every egg is a good egg. Not every egg that we fertilize successfully fertilizes, and only half or so of the embryos that fertilize continue to grow and develop. When you go to biopsy those, there's going to be an age-related aneuploidy rate, so that the older you are, with the exception of using donor eggs, and it's the age of the donor that counts, we have an expectation of what percent of embryos, even though they're good-looking embryos under the microscope, just are not normal genetically. So we've got sperm issues, egg issues, technical issues. We've got genetic issues and then uterine factor issues and host issues. All those things put together will give us an idea of what to expect. So when you ask a simple question, what's my odds of getting pregnant? We can give you a general answer, assuming that we have a normal embryo and a normal uterus. We can fine tune it as we get further along and we know how you're responding to medications and so forth. But all of these different factors do play a role on how successful an IVF cycle is going to be. At the end of the day, we need a normal embryo to put back in the uterus and a healthy uterus to put it in. In patients who have problems either in not producing good quality eggs, we have the option of using a donor egg. Similarly, men who have no sperm, we have the option of using donor sperm. If the uterus is a problem anatomically, then you try and fix the anatomic abnormality or consider using a gestational host. If there are factors, immunologic factors or antiphospholipid antibody factors that are affecting implantation, then we have the ability to try and offset some of those medically, or if necessary, if all else fails, to put embryos into a gestational carrier. So all these things make a complicated answer to a simple question, but the first and major key is getting good quality embryos, and that starts at the beginning with us understanding your ovarian reserve, your past history, and really looking at each patient individually to try and get the best possible outcome. So I hope this was helpful, and we look forward to working with all of you, and wish you the best over this long weekend, and have a good day. Take care.